Dr. Pawan Prashar, who is a young rising star. He will be speaking on cataract surgery in compromised eyes.
Thank you, sir. Good morning, everyone. So, after a very clean and very wonderful case by Mahir, it's the other spectrum where you don't have a clear cornea and comorbidity in terms of corneal problem with the visibility in the cornea along with the cataract. So, this patient is a 70-year-old female, post-hydrokeratoconus, around 80 to 90 case, very distorted and very poor vision of the anterior segment. So I couldn't convince her for keratoplasty because the family just wanted a cataract surgery, didn't want to risk the rejection. So I start the case. It was mature cataract. The anterior capsule was very fibrotic, and I tried to do my CCC with the Utrata forceps, couldn't do it. Then I used a cystitome to make an opening in the anterior capsule. And as you will see, most of the instruments, they appear very distorted, and because of the opacity at the apex, I'm not able to look clearly inside the eye. Somehow I could raise a flap, but it tended to run out to the periphery. Everything appears very grossly distorted, and you do not get the stereopsis. So somehow I was able to complete a large rhexis, and then you see the cannula, it appears curved, otherwise it's a straight cannula. So then I start the phaco. I usually make a trench and then do a phaco chop, but I was not able to get the plane of the depth. So in such cases, it's the trick is to put a large diameter RGP over the cornea. It works just like the patients are able to, keratoconus patients are able to see better with the RGP. Here the surgeon can see better. It cuts off the aberrations and the distortions. And now I have a good stereopsis, and the rest of the steps are done like in a routine phacoemulsification. So once whole of the cortex is out, you remove it, and you can see the handpiece, it's very distorted. Place the IOL in the bag, and the patient did well. Another patient, 65-year-old male, referred for therapeutic PKP. I did a PKP, but developed a cataract, and obviously for visual rehabilitation. In such cases, a lot of synechiae, shallow AC, and graft I'm biased towards proceeding with the SICS surgery. Do not want to risk the already compromised cornea with the phacoenergy. So you do the tunnel and then synechiolisis. Pupil was atonic and fibrosed, so I do posterior synechiolisis and anterior synechiolisis. Then stretch pupilloplasty to make a space in the anterior for the pupil. Then the rest of the steps are followed. The large diameter CCC, the capsule is gently rotated out of the capsular bag, and repeatedly fill the AC with viscoelastic so that the endothelium is not damaged. As per the size of the nucleus, the incision is extended, and here you can remove with the visco expression. The rest of the steps are you do an IA, just like with the Simcoe cannula. And as per the patient's preference, the IOL is implanted and dialed into the capsular bag. So viscoelastic is aspirated, air bubble is injected. The patient did well with the best corrected vision of 6/12, despite having a therapeutic PKP. Then the other set of procedure where you have to address the corneal problem also. So this is a patient with corneal opacity. So here I would proceed with the PKP, and then a lot of synechiae are there. You do the synechiolisis, and after the trephination of the cornea and removal of the diseased cornea, and then try to do a large diameter capsulotomy like a can opener. And sometimes you have to, with the cannula, you have to gently hydrodissect and move the nucleus, and sometimes it gets prolapsed by itself. The cortical matter is then removed with the open sky procedure method, and it's probably very stressful time. We do not want to rupture the posterior capsule because then it will be very difficult to manage here. So whatever cortex is there, it is removed from the capsular bag. And then you can put an IOL here also, but if the thrush is more, what I do is I place the cardinal sutures first. And so the second or 6 o'clock suture is probably the most important. It helps in redistribution. And here I'm doing running sutures all around, except for the last quadrant from which I'll place the IOL, because now you get good AC with the viscoelastic inside there. So rest, then the sutures are completed. And the cardinal sutures are removed. The sutures, the tension is adjusted, and critical is the knot is buried to prevent any vascularization or irritation to the patient. And sometimes you do not want to put in sutures, because as cataract surgeon, we do not, sometimes it's like sutureless keratoplasty. So here, a patient with a corneal edema and cataract. So here we are going to do a DSEC triple, where first you debride the edematous epithelium to improve the view. Next, to make a sclerocorneal tunnel, and then CCC. The vision is usually poor in such cases, but you proceed with whatever method you can. Use a dye, do a large rhexis. You can do a phaco or SACS depending upon, because the incision anyway is going to be large, because I have to put a DSEC graft. So I usually do an SACH in such cases. Then cortex is aspirated and put in. So the IOL is injected under the BSS here. We do not use viscoelastic because it will interfere with the adhesion of the graft. Then the DSEC procedure is started. So you mark the cornea as per your desired size of the graft you are going to place. The Descemet membrane is cored, and then it is stripped with this Descemet stripper. Anterior chamber maintainer is applied, and the pre-cut cornea is brought into field, and I usually do like a 60-40 takeoff fold, and it is the graft is placed inside the anterior chamber, and the AC maintainer is turned off. It is gently unfolded, and then you inject a large air bubble underneath the graft to tamponate it against the host. Graft is centered with the strokes, and this is post-op day, well-attached graft. And after 2 months, best-corrected vision of 6/9. This is pentacam, well-attached grafts, and you can see, appreciate the detergescence and clearing of the cornea from the pre to post-op. Thank you very much for your attention.
Thank you, Dr. Pawan Prashar, for excellent job you have done.
Thank you, sir.
Because this is one of the difficult situation. Any patient where cataract surgery you do, and there is a compromised cornea, that is one of the most difficult situation.
Right, right.